Okay, here we go. Right, so welcome to this workshop, everyone, on health economics for businesses selling to the NHS. You will be pleased to know Liz Trust is actually not going to be presenting this workshop. So just some introductions to members of the Health Innovation Northwest Coast team. I'm Steve. My job is to help businesses do business with the NHS. Phil helps me plan, organise and deliver these workshops, so thank you, Phil. Laura and Alex are in the boardroom at work in the office, and Laura leads. They both lead on the valuations and real valuations. We will be recording this session. I believe we've already started that. Can I ask everyone to remain on mute and not ask questions during the 40 minutes of presentation, which will be delivered by Ben and Mike from Unity Insights. We will have 15 minutes of Q&A, and if it needs to roll past the 1 o'clock time and people want to stay on, that's fine. But this is being recorded, so you can look at it again and share it with colleagues. And if you, in that last Q&A, if you've actually invested or been involved with how health economics works with a company or a product, please just raise your hand after the presentation because we'd love to hear from you. Right, I'm going to pass it over to Mike and Ben.
Thanks so much, Steve. So quick introduction. I'm Ben Williams. I work for a company called Unity Insights. We are a social enterprise embedded in the NHS with a vast experience of working with healthcare professionals, innovators and commissioners supporting specific NHS challenges. Having historically been part of Health Innovation Kent Surrey Sussex, we maintain close links with both National Health Innovation Network and the 15 individual HINs. Part of my current role includes leading with bespoke support that we provide to Health Innovation Northwest Coast across a range of analytical and evaluation requirements. One particular area is around health economics. So Laura and Steve have invited us today to speak to you to provide a crash course on broadly why is health economics important. Then we're going to delve into a couple of potentially useful approaches and finally make sure you leave with some key takeaways. So with that, I would like to introduce my colleague, Mike Long. Mike has extensive experience with economic modelling, statistics and research, so is the ideal person to take you through today's session.
Great, thank you very much, Ben, and thank you very much, everyone, for joining. As Ben was saying, just the agenda today, just going to go through what health economics is, why it's important to the NHS, a couple of modelling techniques that we use, and yeah, the few takeaways. So health economics, what is it? Well, if I didn't know what something is, I'd throw it into Wikipedia and see what it brings out. So here we've got health economics as a branch of economics concerned with issues related to efficiency, effectiveness, value and behaviour in the production and consumption of health and healthcare. Okay, so let's break down a few of those things. I think we know what efficiency is, essentially just the allocating available resources, just to ensure that we get the most out of them. Effectiveness is obviously the consequential effects. Value, ensuring that we are generating more benefits than costs usually. It doesn't always have to be pound signs, it can be other types of benefits. But the one that's important for healthcare certainly is behavioural. So obviously, being an economist, I think everyone acts rationally, but we know in healthcare, we know just in general public, people don't usually act rational. And that's why health economics is important for trying to understand the real world implications of health and how that affects other parts of the system. So why do we use it, and why do we use it for the NHS? We want the NHS to do well. We want things to come into the NHS, but we also need to understand whether things are worth implementing, something new coming in. It's very difficult to make decisions when you don't have a good evidence base. And also the NHS is very complex. We know that there is finite resources, so we need to understand where best to put those resources, where best to allocate. A lot of times it comes down to this opportunity cost. We've got a certain amount of resource, but where best do we allocate it? Just an example is something like IVF. So IVF, of course, it costs around £4,500. Now, if the NHS has got that £4,500, what else could it do with that money? So at the moment, that kind of money will buy you a third of a cochlear implant, perhaps half a heart bypass operation. But because we're thinking about government money, public money, this is money being spent on public services, that money could also be allocated to 2,000 school dinners or a quarter of a junior school teaching assistant. Other things though in healthcare, things like 11 cataract removals, 85 MMR jabs. Where do you put that money? But as we are talking about public money as well, it actually is the cost of a thousandth of a Challenger 2 military tank for the defensive budget. But essentially, it's the same pool of money. It's government spending. So what type of health economic models are there? The ones that we're going to go through today are two that are often used in application in the NHS and for evaluations and real world evaluations. So cost benefit analysis, essentially what you're doing is looking at all the costs and all the benefits, monetizing them and then comparing them against each other. Is there greater benefit than the cost you're spending on them? Strengths is that the fact you can probably compare lots of different interventions because you're looking at the costs and benefits of each intervention. You can also look at social benefits. So you're looking at not just health gain, healthcare resources, but you're also looking at public benefits, environmental benefits, quality of life benefits, these other things, as long as they can be monetized. And that sometimes is the weakness in this model. There can be inconsistencies in terms of methodology, and also having to monetize all the benefits you can think of can sometimes be problematic. It's usually used at sort of system level, so usually at an ICB or PCN. You can actually do it at the whole of the NHS level, and it's usually used to calculate the return on investment. So understanding whether something gains value at scale and whether it can be or should be adopted at scale and accelerated in the NHS. Another type of model is a budget impact model. So this looks very much at the bottom line. How much is this going to cost me? How much is this going to cost me different to what we're currently doing? And it's usually around affordability. How does it affect my bottom line? Can I actually afford to implement this where I want to put it? So they're usually quite easy to create. The weakness in them, though, it doesn't always look at all the impacts that are and all the benefits that a particular intervention might have. It also looks at it very short term. What does my budget look like this year? What does it look like next year? Can we afford it? So it's usually used by local commissioning. It's usually a decision maker that will have a look at a budget impact model and decide whether they're happy for those changes in budget, essentially. It can be used at scale in terms of national decision making as well. But as we go through the budget impact model later, you'll see how you can adjust the model itself to cater for your personal and local needs and parameters. So a little bit of guidance to start off with. A lot of the modelling that we do just follows essentially the Green Book guidance, which is from the HM Treasury. It's a really large document. There's loads of supplementary pieces off the back of it, but it's around the guidance of appraisal and evaluation. So we stick to this because it is public money and we want to make sure that we're evaluating it and modelling it in the right way. You've probably heard of the NICE evidence standards framework. In particular, this is for digital health technology. So again, this kind of pulls together the clinical standards for what you need to do to show value. The interesting thing here, I've got a couple of bullet points at the end there, is that they're happy for a lot of the modelling to be based off different data sources, whether it be a clinical study, if there's no real world data. There is real world data from pilot sites. Obviously, using that is going to be a lot more beneficial. But also, some modelling can be done from just clinical or social care professionals' opinion and other literature-based pieces. So let's go into some of the modelling techniques. So the cost-benefit analysis, as mentioned before, we're looking at all the positive benefits and looking at against the cost. So it's quite self-explanatory for what it is. But as we go into a bit more detail, we need to think of what types of benefits there are. So we've got cash benefits. So this is basically money back in the pocket. It could be something like a prescription of a drug. That is money back in the pocket. There is other things like non-cash releasing, and this is where you're thinking around resourcing. If you free up a bed day, for example, you're not going to put the money and take the bed away and put the money back in your pocket. You're freeing up that bed for someone else to use. Same with time taking for clinicians, for example. If you save an hour of a GP's time, you're not going to get rid of one of the GPs. What you're going to do is make sure that GP can utilize that time And you can monetize that essentially by understanding how much it costs to keep that GP on for an hour. And that's the value of that time being released. There are other social and public benefits. So if, there's a large thing about waste and CO2 output, lots of things around environmental, and that can be monetized. There are ways to do that. But there's also thinking around what the patient has to go through. Do they have to take time out of work to travel to have a particular intervention, to have a particular care? Again, that can be monetized. You can put a cost on patient travel time, but also obviously the expenses they'll have to go through if they have to travel to a hospital rather than a local GP practice, for example. So another type of social benefit is quality of life. This is obviously one that you don't really think is money back. It's not really money back in the pocket of anyone, but it does provide a way to show essentially what we're trying to do in the NHS is improve people's lives, and this is one way you can do it. And there are ways to monetize quality of life. So if you can improve quality of life, if you can reduce mortality, we can measure that in terms of pound signs. So all of these things above can work the other way, that you can sometimes think, oh, we're gonna improve all these things, we're gonna put money back in the pocket, we're gonna save time. But sometimes when you look at real world data, they can go back the other way and actually become a negative benefit, for reasons that you might have to see it in the real world to actually understand. So we just call these disbenefits if something you feel should be beneficial actually becomes costly in that way. There are other benefits you should think of outside of any of those that are monetizable. Quality, obviously these you can measure, but you can't necessarily monetize them, such as things like staff satisfaction, patient satisfaction, ease of use, and things like that. There's other qualitative benefits which are not quantifiable or monetized, and these are the sort of things like case studies and interviews. And it's always recommended in evaluation to use this mixed methods approach of understanding all the pound sign benefits, but also understanding the context around them. Why are we seeing these in the particular magnitude that we're seeing them? And sometimes these things can actually bring out why we might see a disbenefit or additional costs incurred. How do you know what type of benefit you've got or disbenefit you've got? There's just a useful little flow diagram here for anyone just to have a look at to understand where they feel their benefits will reside. On the other side, obviously, we've got costs, and these are usually ones that fall within the NHS, or we call them PSS, so personal social services. Obviously, there's fixed costs, implementations of new interventions, initial equipment. You might have to go through staff training. Then there's other sort of variable costs that might be required, such as consumables, things that kind of one use per intervention, per staff or per patient. Ongoing training, there might be for digital technology, license fees. So a lot of these you can see are pretty much incurred by the NHS, whoever's commissioning it. But there are other indirect costs that you might need to think about, and that's the knock-on effect of this new intervention coming in. It might affect other parts of the service. So if you're actually referring people from primary care to secondary care, you're thinking, great, I'm saving lots of money in primary care, they're all heading off to secondary care. But actually you need to make sure you're accounting for that additional secondary care usage. There are also environmental costs and the other societal costs that we discussed earlier that might be incurred, such as environmental and plastic waste, CO2, things like this. And yeah, non-monetizable costs also work the other way in terms of quality and qualitative. So other things where people might find new technology, new intervention more difficult to use and may reduce satisfaction, and patients may feel the same. So the best way to go through this is through an example. Some of you may or may not heard of the capsule sponge test. It's actually part of it's called the heartburn healthcare checks. You may have seen them in and around the Northwest. And essentially it's a capsule sponge test, which is there to understand whether there's any early detection of esophageal cancer, or diagnosing Barrett's esophagus. So the idea is that you're able to have this capsule sponge test instead of getting referred for an endoscopy. This particular project tried to understand whether the use of the capsule sponge test in primary care, so through GP practices, or community care at community diagnostic hubs, for example, whether it was worth implementing them there rather than having to refer people on to endoscopies in secondary care. Because we know an endoscopy is a lot more difficult, it's a lot more expensive. If you can have a capsule sponge test more locally, you assume that there's lots of benefits to be had there. So the idea is we're reducing demand on secondary care resources and hopefully freeing up some waiting times in endoscopies, because you're able to take a lot of people off the endoscopy waiting list, give them this test instead. So there's our benefits: reduction in endoscopy procedures. Obviously those procedures will still happen, but you're freeing up that capacity for someone else that may need something more urgently, and away from this sort of Barrett's and esophageal cancer pathway. There's also the case for the fact that this capsule sponge test is a lot easier to actually take. An endoscopy is quite uncomfortable, so we thought that let's model some DNAs in that, some do not attends in that, and understand whether there's a bit more of a client uptake, a patient uptake in terms of this. The social benefits we looked at, we had the reduction in travel time. Obviously, they're traveling now to their primary care or their community care in order to get this diagnosis test. And that's for some of the places in the Northwest, around sort of Burnley, Oswald, places like that. Having to travel to secondary care they were 10-15 miles away, when they could go and get this test round the corner in their GP practice. Obviously we wanted to make sure we were capturing that particular benefit and the things that come with it, such as the travel emissions, making sure patients are able to actually travel, and that kind of links in with the DNAs. The fact is it's more accessible and they're more likely to attend. There is actually a lot of unnecessary waste when you have an endoscopy, whether it be gases, whether it be disposables. This is, as you saw before in that picture, a small capsule on a piece of string, essentially. Very small amounts of waste compared to the endoscopy. There were lots of other things we had to think about for the costs, though. So obviously the capsule sponge test itself, but actually you think of the staff training, you think of implementation of the additional staff costs, and then the environmental impact of the other side. So you are producing some waste as well. You might be saving some of endoscopies, but you are producing some with the actual capsule sponge test. There is obviously the thing that this capsule sponge test, it's not just that and that's done. A lot of times you'd have a capsule sponge test, about 15% of the time it would show alarming symptoms, so you would be referred for an endoscopy anyway. But the fact is those 85% that you didn't refer for an endoscopy are saving that. There wasn't any adverse events, but sometimes there are, especially with devices like this. It's on a piece of string. There wasn't any string snaps, but there's something like that, or the capsule sponge gets lodged or anything like that. But again, we had to make sure we took that into account. So once we got all the benefits together and all the costs together of the pilot sites for this project, we then monetized them and created the cost benefit analysis. So essentially it came out with a ROI at the bottom there of a slight loss. So I just want to draw attention just to some of these large costs in the middle here. And this was for an 8-month pilot, and there was a large additional staff cost of setting it up, having to make sure the clinics run smoothly, having standard operating procedures created, clinical leads input. So there's quite a lot of additional staff costs into this that were incurred in the duration of the pilot. And that is why the ROI actually sort of flipped over, and it became a bit more of a cost. So the total net benefit was actually minus £18,000. To the right hand side, there's quite a few additional things that we did. We did some sensitivity analysis, and we tried to understand the variability of what the outcome could be. It's very difficult to say this definitely happened. So actually what you do is you create some variability in the inputs that you put in. Did we save this amount or did we say this amount? You put ranges, a min max range, you run it through a Monte Carlo simulation and try to understand what the largest things are that impact the outcome. So what are the largest assumptions we're making that are going to impact the overall result? So after that, we thought, okay, great, we can see what's happened with the pilot, but what happens if we continue this for the rest of the year? So we've done it for 8 months. Let's continue for the rest of the year. Let's continue it for 5 years. Let's see what happens. And actually, you can see here at the bottom that negative ROI becomes positive because of that large additional staffing cost. That's been now kind of swallowed up with more patients coming through the door and more benefits being realized. So it tips it over into something a lot more positive. And over a 5-year period, you can see actually the benefits are around £200,000, which is absolutely great. But it just sort of reiterates that point of, during the study, we found it was a loss, but actually, if you continue doing it, get more patients through the door, then we can see a positive ROI over 5 years. And this is what's good about one of these cost benefit models, is you can look back and see negatives, but if you think, okay, what's actually going to happen in the future? What's that counterfactual? What would have happened without this, and compare it against it. And you can see if we continue using it, eventually more patients will come through the door and it will become positive. And these were sort of the outcomes of the 5 years, using that sensitivity analysis and running it through Monte Carlo simulation. We were 90% sure that it was going to, the outcome over 5 years was going to be between -60 and plus close to £500,000. So we're pretty confident this was going to return positive outcomes. And you can see here, this was the sensitivity analysis. The main thing which actually affected the outcome was the uncertainty around how much an endoscopy costs. And then the other really important things were obviously ensuring that there was successful tests. Someone comes in, they spend the money on the capsule sponge test, but that adequacy needs to be high. That successful test rate needs to be high. Otherwise, you're wasting the cost of the capsule sponge test. So what did this lead to, and why was it important that we did it? So it identified a lot of those points around where are the large costs, where are the large benefits. We know that because there was a high initial cost, creating those more streamlined standing operating procedures was really important to keep those costs down and improve the value. We also know that patient throughput, more people through the door and increasing the success rate of the test, needed to be optimal in order to gain more of that value. It also asked questions as well. It didn't answer the question around what, the value of the endoscopy. I think we sort of went out and said the cost of an endoscopy varies massively across sites. So actually we need to understand that a bit more. So let's go out and just maybe find a bit more information around how much an endoscopy really does cost the NHS. We did find that it was quite high because there's so many waiting lists out there. A lot of secondary care sites actually outsource clinicians to come in and do the tests in order for them to meet their targets. So actually, are we going to be reducing the reason to do that if we are shortening down the waiting list and taking people off the waiting list? So there's other things to explore in that. I think the main thing though is it showed that financial and economic sustainability at scale if you are continuing to do this over the next 5 years. And what it actually led to was some more funding for a secondary evaluation, which is just going to be concluding soon. And this is been done at a much larger scale. So we know this pilot site for Cytoprime 1 was only around 150 to 200 patients. Just to say that we've just concluded Cytoprime 2 and it was around 2,000 patients and showing positive results. So we've done cost benefit analysis. We're just going to have a little look into the budget impact model. So essentially what you're trying to do is understand all the costs involved in the current pathway. So for the capsule sponge test, for example, the current pathway is essentially you get referred for an endoscopy. Then you look at all the costs incurred in the new method, and this is slightly different. You're just looking at costs here. You're just looking at what the commissioning would be from a cost value and comparing those two budgets. So again, by example, I won't go through this diagram too much, but this is the pathway for a capsule sponge test essentially. And you can see at each stage it's got a percentage, it's got the likelihood of someone going down each of the paths, and a pound sign would be associated to each of these points where there is a cost incurred by the NHS. And you're comparing this essentially against the normal pathway and looking at all the costs. So once you've developed this, the pathways, you then want to be able to have something a bit more customizable. So the budget impact model itself, actually at the front end, you're able to put in some custom inputs. Let's have a look at what it looks like, for example, on the screen at Burnley Group Practice. So we can see the referred population, we can see how many GP practices within this sort of region, and we can see some volumes of patients. So the idea is that the model is customizable to exactly where you want to look at. And here we can see that there are other inputs that you can put that are a bit more, these are more clinical ones, to be fair. There's a lot of default values from the study itself, but you can think of, if we collect our own data or if we look at a different data source, maybe you can change some of these other parameters to be more relevant to your local areas and local needs. And then finally, things like unit costs and costs of training, cost of people vary up and down the country, especially that endoscopy. You can see in there we've got the endoscopy cost of £912. There's something below that called a market force factor, and that's something that the NHS often applies depending on where you're looking at in the country. So somewhere in the northwest, for example, might cost the NHS slightly less than it would do central London. So it's just thinking about those local costs, and this model allows you to do that, put in your local costs and run it through the model. And hopefully that will bring up something like this, which is rather positive, where you've got your net budget impact, the in-year budget impact. What does the bottom line look like for this year, etc., for the next 5 years? So this one's based on some of those inputs we saw, slightly different to the cost benefit analysis, where it was just a single analysis giving you a single answer. This one will give you whatever answer you want by the inputs that you put into it. Now, the important thing to realize here, though, is that this is about people's budgets, and where these costs are incurred can often be different parts of the system. For example, in this one, the endoscopy costs, they all happen in secondary care. That's where your savings are. They're in secondary care. But this is cytoprime in primary care. So all the costs of the capsule sponge test are incurred in primary care. So you're going to put more money to spend in primary care. You're going to have to increase the budget in primary care, but the reduction in the budget in secondary care is far greater. So actually you're having a positive budget impact model on the system, but those benefits, those cost reductions are incurred in different parts of the system. And that's really important. And that's why it's often important to put this in front of someone who's in charge of both budgets, or not quite both budgets, but someone who can have influence on both budgets. Other than all the numbers on the screen, there's other ways to show the data, just as graphs. But what's another really interesting thing is a break-even analysis. So something like this you can use as the innovator, as the supplier of a product. You can think, okay, with everything constant, what happens if I change the cost of the capsule sponge test? Where's the break-even point? At what point does this become money back in the pocket for the NHS? Other things like patients attending, with this you can see there's the inception point of about 50%. As long as 50% of patients who are invited to attend, you're going to break even at least. And this is successful tests, so that kind of comes back to some of those things that we brought out in the cost benefit analysis. We know percentage of successful tests was really important, so let's model it in a break-even analysis in the budget impact model. And you can see it's around the 70%. As long as 70% of the tests are successful, you should be gaining value in this circumstance with everything else constant. So why is this important? Well, what it actually allowed is the Lancashire South Cumbria Cancer Alliance to continue the use of the capsule sponge test for Barrett's and chronic reflux patients. They really wanted to understand, how much is this going to cost? Are we going to continue using it and doing this test for the next 5 years? And then putting their local figures into the budget impact model allowed them to say, we can afford this. We can show financial sustainability. So it's continued to be used, which is absolutely fantastic. But this is mainly down to the bottom line of cost figures. It doesn't look at all the social gain. So you've got to think from a commissioner, yep, I can afford this. Yep, great. It's providing value to me, to my clinics, to my primary care network, everything like that. But actually, you're providing a lot more benefits to patients, a lot more benefits to society that aren't usually captured in a budget impact model. So there's a couple of models. There's just a few takeaways when thinking about health economics in general. And these are, take some of these with a pinch of salt, but it's just a few things that I wish I sort of knew when I first started doing this kind of work about 7 years ago. Meaning of work. People will use different words to describe the same thing, and communication is really important when you're talking to the NHS, talking to clients, talking to anyone. What are you trying to achieve? Being really understanding between you of what you're trying to achieve at the end of it is really important. And actually, as a decision maker, they need to be very clear on what information they need to make their decisions. So linking that together, what are we trying to do? Why do you want to do it? That communication is key. Data. This one is always one of the pinch points when it comes to modeling, comes to any analysis, comes to any kind of proving something works. A lot of work that we do is in the real world. So we get real world data, and it can be very gappy. It can be very woolly. It can be difficult to get a hold of, especially with GDPR, and that's a whole nother kettle of fish. So there's always a level of uncertainty that you'll have when you're doing modeling. And the main point here is that you need to be just transparent with that data. We've used this, we've needed to make this assumption and this assumption. You essentially will always have to make some assumptions down the line, but as long as you're transparent, as long as it's logical, reasonable, and there's other logical ways that you've taken and steps that you've taken to say, we've used this because we know this is usually the case that happens when something happens. Something that came up in the green book, so some of the guidance that I showed you before, is something called an optimism bias correction, and we use this quite often. It's essentially, we're all very optimistic about something brand shiny, new, excellent, and what an optimism bias does, it says, right, what assumptions have we made that makes that look really good, and actually, are they reasonable to assume that's going to happen again in the future and again at this place or in this particular setting with these particular patients? And what it does is it just applies a percentage that kind of cuts off that benefit. So if we've got £1,000 benefit, great, per patient, but that's in this setting with this data at this particular moment in time. Next year, am I going to be confident that patient's going to see that £1,000 benefit? Unsure. And then you apply this optimism bias. So that £1,000 might become £800. A lot of that guidance is within the green book. But yeah, data is always an important one. I stress that a lot. Value. As I mentioned there on the budget impact model, the value being created was at different levels, and the value that we saw the capsule sponge test bring was in secondary care. You reduced the endoscopies, but is that value to the primary care site? Again, it's about perspective. Who's in charge of that budget, and also the patient itself. Are you looking more deeply at the patient benefit, the quality of life benefits? A lot of things are very good, but actually you need to look at all these other benefits, including quality of life. You'll probably say don't focus on the ROI, because there's lots of other good things that come out of this, but at the end of the day, people will, especially if it's big. If you've got an ROI, if you've got a huge benefit coming out or really negative benefit coming out, people are usually just going to say, oh, that's the answer. So one of these things is about not always quoting that single figure and using things like the sensitivity analysis, using best and worst case scenarios to create a range. And also, when you do see a big ROI, it can sometimes raise eyebrows. If you come back and say, oh, we're going to return £10,000 for every £1,000 spent, that's going to raise eyebrows. What's your methodology? What's the scrutiny? The higher the ROI, the more scrutiny in the model usually. So just treat it with caution. How has it become so big? If it's that big, why has something like this not been done before? Keep working on it. This is just the point around probably the data and the use of something. You don't just do a model, send it off, there you go. Lots of iterations is great, especially when you get new data, better data, more insight into how particular interventions are being used. You might want to adjust models. You might want to account for other new emerging benefits that you didn't think of. So always be flexible when it comes to modeling. Don't just say one done, we're done, there you go, see you later. And at the end of the day, even though everything's rosy, great, and excellent, there might be a decision that's completely different to what you expect anyway. It's usually health economics is not conclusive. A lot of times it raises more questions than it answers. But the fact is, it's there to help make decisions, and the decision might go another way anyway, even with there could be other reasons as to why. Things like strategy, things like local needs, operation, managerial, ethical, clinical, lots of other things why positive return on investment may not always result in something being adopted. Just a last little quote here from George E.P. Box. Essentially, all models are wrong, but some are useful. But don't worry, we're here to help. So I'll conclude there and pass back to Steve for the next section.
Yeah, Mike, that was brilliant. 35 minutes too, so you bought yourself 5 more minutes of Q&A. If we stop sharing the slides,
I can do that. I can shop. There we go.
Yeah, either you or Phil, and then if people want to put the cameras on or raise their hands or throw anything in the into the chat, just before I come to the first thing I can see from my old colleague Andy there, is what we were trying to achieve today was to ask the question why health economics is important to the NHS, and how it can have a business selling to the NHS. And obviously, I think Mike's done a great job of presenting something that's quite complicated, and hopefully you found it a bit more simple to understand. I certainly did. But the two main approaches are that budget impact model and the cost benefits analysis. And I like the Cytosprint example, and I wondered if Debbie and Sarah, who are on the call, could just quickly say something, because Sarah, I believe, is from the company and Debbie was involved in the evaluation. I don't know if Laura wants to say anything, and I can't see everybody. So is Sarah there?
Hi.
There you are. Good morning, good afternoon.
Afternoon. Yeah, it was really useful for me even. I think there's definitely certain points that I would pick out in particular, are that crossover between who is in charge of the budget, so primary care and secondary care. You really do have to involve everyone, because the ownership of the different parts of the budget is where we've found, previous stumbling blocks or things that we'd need to overcome. So it's definitely important to adjust the budget impact model to be able to answer each question for the various different people involved.
Yeah. Debbie, did you want to say anything?
Yeah, I was just going to say, for those that don't know me, I'm Debbie. I'm Patient Public Involvement and Engagement Lead here at Health Innovation. Hi, Mike. I can see you smiling there.
Hi, Debbie.
So, yeah, I just think that the patient input was really important in this as well. Mike touched a little bit on people not turning up for appointments, and we found that simple questions and asking them why they hadn't gone helped uptake. So, for example, in the original pilot, they used the word string. It was called pill on a string, and we got feedback that patients didn't like the word string. It was a perception that it was thick and it would be down the back of the throat and feel uncomfortable. So with patient guidance, we redid the patient leaflet, called it strong thread instead of string, and the uptake and attendance increased quite dramatically. So something simple like that can be really cost effective as well, because it costs people if people don't turn up for a patient. But I think you can't underestimate the importance of patient input from these things as well.
Yeah, so that's a great example of one of the points Mike made at the end there when he was doing key takeaways, the communication. People have to comprehend things and feel comfortable with them. Andy, do you want to ask your question, or shall I ask it on your behalf? I can't see you on the screen yet.
Oh yeah, you see me in my. No, it was just really because obviously our ROI. If you're speaking to an accountant, they might want a larger ones there. It goes in with the whole sort of dynamics, but is that an ROI? Will accounts or the NHS look at ROIs less than 50%, less than 10%? So is there a sort of, obviously the better it is, the larger it is better, but is there something that they look at? So in business, people might look at it differently for their investment portfolio that they're looking at. NHS, I know it's different, but just from your experience or expertise.
A big ROI. I can see your question now. So we, our kind of external QAer, he's the deputy director of ONS, and the one thing he always said to us is, if you get an ROI of over 800% then there's alarm bells. There's people who look at that and just think that's pretty high. To be honest, when you dive down, look at all the benefits and costs of most of the things that we look at, it tends to be, the positive ROIs anyway tend to be between about 0 and 200-300%, and that's being prudent as well. So that's realistic, and we're being prudent. So actually you might see these ROIs that are a lot larger in reality, and that's why doing a lot of the other analysis, such as the sensitivity analysis, the Monte Carlo simulations, to understand what a min max could be, that could be more important, because that way it gives you confidence that it's going to be between X and Y% based on the modeling that you've got. So again, the ROI, as I mentioned before, it's a number that gives you an idea, but actually the ROI should usually be a range because of the uncertainty.
Yeah.
Okay, thanks.
And it's interesting. We often get asked, how much does it cost if they're looking at something new? But often the clinician is not able to describe how much their current way of working costs. So they want to know how much the new cost is, but they can't describe their current costs. And what they sometimes don't appreciate is the cost by not changing that have unintended consequences or hidden costs. And we also often talk about something called, if you pay for something in a setting, don't underestimate the system potential to make savings. And that probably doesn't happen as often as we need it to, because unfortunately NHS isn't a very commercial organisation, so it does not tend to think long term and stuff from an return on investment point of view. Daniel, can I bring you in, please?
Certainly. Thanks for asking me and Steve. I'm an entrepreneur. I've been an entrepreneur since the age of around 14, and I'm currently setting up an organisation called Despair to Hope that's going to be tackling addiction and mental health from a lived experience perspective. I've been an expert by experience for the last 22 years. I've been doing a lot of undercover work that you may be aware of. It was me that was responsible for Adrian Charles admitting his problem, which is, I'm not going to go into the full story about it, but I've done an awful lot of work. And I know how to tackle addiction within the NHS from a wellbeing perspective of staff as well as service users. I've had extreme problems with my local mental health trust of engaging with them. In fact, I've waited 18 years to get on the dual diagnosis, now the co-caring strategy. However, I am going to Parliament next week for the second time in a matter of months. And to be honest, my local mental health trust isn't taking me seriously whatsoever. However, there has been some developments, in terms of that. And I found it really difficult to engage from a PPI angle, although now I'll be setting up not only a community interest company, but also I'm a consultancy arm to do with that. However, what does it take for me to get the NHS to be serious on this matter? Because this matter is the most serious matter that this country faces with regards to addiction of not only alcohol and drugs, but also food. I'm pleased to say that I am in recovery for being a sugar addict as well as being an alcoholic. And, a lot of the things that I've delivered, for example, with Lancashire Police, I've got very positive feedback from, as well as other organisations, including Accrington Stanley. So, you know,
Daniel,
I'd just like to know, you know, in terms of a return on investment, it will be an extremely high figure that we're talking about here, but unfortunately, people don't seem to be taking me seriously. So, who do I go to? Who's the most? Who's the person that we go to with these ideas?
Okay, so this workshop's not really about that, but I'd be more than happy to have this conversation with you and my colleague Debbie offline, if that's okay.
Yeah, certainly. By all means.
Yeah, thanks, Daniel, and thanks for sharing. Phil, do you mind putting my work email address and Debbie's into the chat, please, mate? And Debbie and I will follow up with Daniel after this.
But just off the back of Steve, just off the back of that, I mean, if I was to measure a return on investment of well-being of staff and service users as well at the same time, it's going to be really difficult to be able to do something like that from my perspective. So I just wanted to mention that.
Yeah, in terms of economics, there's ways of doing it. I know, you know, we're talking healthcare a lot on this, but there are ways to do and look at social gain with things like this. There are obviously unit costs to the system of addiction and things like that, and there are studies and reviews of people that have been able to monetize those particular conditions. And again, through Steve, I'm happy to share some of those materials with you if you want to start thinking around the value from a pound sign perspective, and that might help bring a few of the things that you're talking about to life.
Okay, so thanks for that, Mike. I'm going to bring in, I think it's Andy Sutcliffe. I saw the next hand up.
Hey, thanks, Steve. Yeah, it's me here. So I'm managing director of a company called Celox BPH, a subsidiary of Celox Medical Medtrade. We've innovated and we developed over the last 13 years a huge amount of clinical data, and now commercialized in many countries around the world with a life-saving device for postpartum hemorrhage. Postpartum hemorrhage is the leading cause of maternal mortality worldwide, and I guess more recently there's been an increasing growth and demand in the requirement for health economic data. We recognise it as something that is covered in some of our clinical publications, but to have a more dedicated health economic proposal. I guess the question really, we've been speaking with a number of companies and had various different proposals put on the table. There's a wide variety of costs, and there's a wide variety of outputs and deliverables and modalities that can come from a health economic study, everything from, you know, white paper publications, conceptual PowerPoint presentation talking about price sensitivity and value, to working models that can be used to engage clinicians individually at an account level. And I guess my question really is, what have you found to be the most kind of essential and effective in doing that kind of model? Because you can be talking tens of thousands, if not into hundreds of thousands plus, to do a health economic model. And it's a lot of work that goes into it. So I guess there's a stepwise approach to, okay, look, these sections or these deliverables are probably critical and the most important. Then you can work your way to more nice to have, which might be a full publication in a global journal talking about the health economic positioning of a device. But I just wanted some feedback on that, really, because we're an SME. You know, we've been around for a number of years. We've saved many lives around the world for Celox in the military. It's pretty much established now as the main global hemostat, one of the main global hemostats in the military segment. But within postpartum hemorrhage, it's kind of innovative.
Andy,
yeah.
Do you mind just repeating your question? Sorry.
So the question really is, in your perspective, Mike, what are the most important and critical deliverables coming from a health economic study like this that will have an impact in helping to change the view of the NHS? So
the first thing that I would say is around a real world study. It's having something already at a small, even if it's a very small scale in the NHS, and getting real world data to understand what the value has looked like in a real world setting with real patients, real staff. I think that real world data goes a long way to show something is conceptually going to work in the NHS. That I would say is very important. And actually then with that, you can start building some of these models, whether it be a cost benefit analysis, looking at the wider, especially if something like postpartum hemorrhage, there's a lot of probably social gain to have there, especially for, people going back to work, people recovering, mortality, things like this. There's a lot of big benefits to be had there. So I would say going for those outputs based on real world data is very invaluable. From a perspective of actually, okay, but we need money to do that. There's a lot of award programs. There's a lot of funding out there, and I think the Health Innovation Network is aware of a lot of these funding pots that will help provide award schemes and funding for evaluations that can help pay for the analysis, pay for the pilot studies and things like this. But again, that's more the HIN's expertise rather than my personal ones.
Let me come in there, Mike, because you've answered it the way I was hoping you would. Myself and my colleague Laura, who leads on the real world relations, we've already had a nice. Have we met with you, Andy, about that particularly? I know we've met with someone else on the call about that. You're on mute, sorry.
Apologies. Yes, we've had conversation. We've had ongoing dialogue with clinicians. So we do have published clinical data. I think it's really now focusing very much on the health economic piece, and a lot of those can be theoretical analysis based on the impact you could have based on theoretical tea tree kind of analysis on a particular circumstance.
I'm going to bring Laura in though, because I think we probably should keep the health economics piece and the real world validation piece separate, because I think Laura's probably going to suggest the real world validation piece would look at maybe the clinical acceptability from a doctor's point of view. Can I bring Laura in?
Yeah, hi Steve, thanks. And I was just going to say exactly that. There's lots of things that we can help you with and work through which bits of real world data you can and ought to prioritise collecting, so that then you've got some of those inputs that Mike's just suggested for that first piece of them. We've not actually met before, so I will also follow up. I'll put my email in the chat and let's have a conversation after the call today.
Yeah, I'll tell you what, sorry, Andy, I was confusing it with Hayden. We've had the conversation with Hayden, who's also on. I've got about 10 of my clients on. So I'll do that as an action, Andy. I will set up a call with Alex and Laura. And I was in London on Tuesday and Wednesday, Andy, and I had dinner with a really nice, someone on our table was an obs and gynae reg, and I told him about your product, and he's very keen for a conversation. His name is Tom, so remind me to
sounds good.
To follow up on that action. Now, I feel naughty because I think Rania had her hand up. Have you still got your hand up? Is it Rennie from Occuwell? No? Have I lost Rennie?
Here we go. Can you hear me?
It's from Occuwell, isn't it?
Yes.
It's the bright light of the sun,
believe it or not, I have sun. I have sun somewhere in the northwest.
What a treat.
Okay, thank you very much for taking me in. It's actually what I'm wondering. We've been involved with Innovate UK and actually in IHR, and we managed some good grant funding to start the work and the health economic study for our project. But I was actually wondering if there is a way of getting access to some of the financial data. So Occuwell is a medical device company based in the northwest, and we have a hardware device and a software analytical modules, and it's a topography machine, so it takes an images of the front of the eye, analyze the images, and then give data according to what the images tell them. It's mainly looking at the health of the cornea, and we're a spin out from the University of Liverpool, and we're built on years of research. But what I'm not struggling with, but what I wanted to know is because as actually Andy said earlier, is that when you go to companies, you get a really huge variety of costs. Some we can afford, and we tipped into funding from LCR before to get preliminary health economic studies, but some are huge, and just for a startup there is no way we can dip into this. But my thinking is there a way of translating some of these data into financial data, and a way I can access the waiting list for people for corneal topography exams. We're actually thinking seriously about bringing this into the primary care, so reducing the costs. It's very similar to the example that you discussed, Mike, about reducing the endoscopy. So if we can do the topography data earlier, and earlier intervention and prevention, rather than wait until people develop certain disease or big issues with their eyes. So
Rania, Can we let Mike answer your question? We might be able to have a follow-up call with you as well.
Oh, okay, thank you. Okay.
Yeah, so fortunately there are quite a lot of ways that's publicly accessible in terms of NHS costs out there. There's quite a few. There's actually, in the slides that I had on the last page of the slides, there's lots of links to publicly available data of reference costs of how much particular procedures cost in the NHS. A lot of them are linked to what's called a HRG code, which is essentially like the procedure code. There are other ways to monetize, and that includes the tariff system. So actually assuming that obviously the tariff is an income generator for hospitals, but you can use that as a proxy to understand the value of particular procedures. There's also other data out there, such as hospital episode statistic data, so HES data, which can show you the volume of particular procedures. That also, on top of that, there are waiting list figures. But hopefully all the supplementary page of information that's provided in the slides, you can click on some of that stuff and start going into and exploring it. There's also a really good one that we use, which is called the Personal Social Services Research Unit, PSSRU, and that's got a lot of individual costs of how much it costs the NHS for things like a GP appointment, for things like hiring a new band 7 nurse and things like this. So there's loads of like detail ways to do it. We pull a lot of that information off of that when we do it, but as a high level kind of understanding the costs of particular things, definitely I would signpost you to them.
Thank you very much.
Thanks, Ronnie. And if we need to follow it up, we can.
Yes.
Carl, I wonder if your question, probably because it seems to have commercial implications, if we can maybe deal with that offline, if that's okay, if you're still on the call, Carl from VisVox.
Yeah, absolutely, that's fine. Yeah, thank you.
So just Mike, after this we can debrief. There's a couple of people I think we should probably follow up with, if that's all right with you, and if we need to discuss costs, we can do that. Joanne Hall, you've said questions in Q&A, but did you want to come in?
I can do, Steve. Yeah, that's fine, no bother. My two questions, respective of time, 2 seconds, I'll just put my camera on. Hi guys, really thank you for the session, excellent information, thank you. My two questions is one reflecting on what Sarah said about when we communicate in the health economic value to the ICBs to make sure that it applies to the different stakeholders within it. We're seeing a strong combination of finance and medicines management working in collaboration. Do you think this is a strong way to approach the ICBs? They're kind of leaning into that focus with their planning. There's variables everywhere. Are these the kind of people that Sarah would suggest you bring together?
That's a really interesting. I know you said finance and meds management, and obviously from the ICB perspective, they need to think about costs, they need to think about resources, and actually health economics isn't just the pound signs, it is economics, it is about resource, it is about utilization of what they have. So sometimes you can do a health economics piece not on a new intervention but a new pathway, and that's a different way you can do it. It's not always about something brand shiny and new coming in, it's sometimes about understanding better ways of doing something with what you've got. So
yes,
I would say taking it with those two points you've got in there, meds management, finance, money, approaching it with those two perspectives is definitely useful for an ICB to understand what their decisions could be in the future.
That's cool. Thanks, Mike. And then one more very quick question. Sorry, guys, I'm going to max on this, and I'll not tell you who I am or where I'm from. I'm not bothered. But it's more of a generic question. So if there's been a nice TA on clinical cost effectiveness on a group of products that is seen to produce the same output, but they don't, it's more of a kind of if it's looked in more detail, it's more cost minimalisation, that some of the items are given different outcomes. Can that be challenged at an ICB level as a reanalysis of cost analysis or not?
I guess what you're talking about there is something with essentially similar outcomes but reduction in cost? Because you're getting effectiveness analysis in this instance.
Joe, what's the product and what's the procedure, so we can get some perspective?
Okay, insulin pumps.
Oh, okay, excellent. Easy to understand.
Hybrid closed loop insulin pumps. So we have a TA's December where there's been a generic, it's amazing, and a generic nice TA approval, clinical cost effectiveness for the UK. But it hasn't been drilled down on specific, and each system, real world data and RCT demonstrates there's enough information out there that systems do have different outcomes. So it's almost, there's some measures being taken with a cost minimalisation approach. And I don't know the answer.
No. Now that we've got a perspective, can I let Mike answer the question?
Yeah, sure.
I'll give it a go. I think what you're basically referring to there is that this particular product will work differently in different areas. Is that what I sort of heard from that?
No, what you were right at first, Mike. So the outcomes haven't been ideally measured between each one. So different levels of outcome data, which will then in turn affect the health economics.
So I guess what the problem there is, a consistent way of measuring the outcomes. Is that a problem that there is? So that needs to be an answer there. That it needs to be that the same data needs to be collected in terms of outcome measures to understand whether the value is the same across all of it. It feels like it's a consistency issue and making sure that the outcomes are measured the same way to show
consistency and capture. Joe, would you be interested in having a follow-up call with me?
Would be grand, yes, thanks, Steve.
Grab my email out of there and just pop me an email and I'll contact you next week. Right, listen, I'm going to call it to a close. This has been fabulous. I mean, we had 102 people registered. Most one of these workshops, we had 57 in attendance with about 5 colleagues, so thank you for that. And Mike, you still had 45 people here in the Q&A, so a great job, mate. Thank you very much.